So the first talk, we have the pleasure to introduce Catrin Moore. She will talk about us about the global burden of antimicrobial resistance and how this evidence is informing new studies. Catrin Moore led the global research on antimicrobial resistance, the GRAM project that is based on the Big Data Institute at the University of Oxford. She partnered with the Institute for Health Metrics and Evaluation and Tropical Medicine. They analyzed the global data to estimate the global burden of AMR. She's now based at the St. George University of London, where she's an investigator on antimicrobial resistance, prescribing and consumption data to inform country antibiotic guidance and local action, the ADILA project. And she's, of course, one of the authors of the landmark paper that was published in a JAMA a few weeks ago. So we have the pleasure to listen to Catrin. She had to pre-record her talk because she was not sure she would be available directly during that time, but she will probably be available for question and answers just after the talk. So please save the question that you would have to her, or you can also ask it on the platform.
Hello, good morning, good afternoon, good evening to you, wherever you may be in the world. I am sorry not to be with you in person, but I hope to be with you at the end of the talk for any questions that you may have. I want to thank the organisers for inviting me to present today, and would like to present the work that I did while I was based in the University of Oxford on estimating the global burden of antimicrobial resistance, and then move on to how this evidence is informing new studies, which I will be involved in, based in St. George's in the University of London. And I just wanted to go over a little bit of how the political will has changed over the last 8 years with regards to AMR. So in 2014, the UK government first commissioned the O'Neill report, which then led to the Global Action Plan and the glass surveillance system being adopted in 2015, all the way up to last year, where AMR was on the G7 and the G20 meeting agendas, which really made a big change over that time. The other change that we've seen is a change from a focus on human health to now including animals and environment in more of a One Health way. We've also seen that the Sustainable Development Goals, which always implicitly included AMR, now explicitly have a new indicator to look at the percentage of bloodstream infections that are due to two resistant infections, so methicillin-resistant Staph aureus and E. coli that are resistant to third-generation cephalosporins. And we also have the WHO list of critical pathogens as well. Moving on to the GRAM project, where we estimated the global burden of AMR, we really collated the data that was available globally to understand the mortality and morbidity due to AMR. Now today I'll concentrate more on the mortality and how many people died due to AMR in 2019. And just to remember, this work was only for humans, human disease and human resistance. So within our modelling, we examined two different population attributable fractions, where we looked at an equation where drug-resistant infections were replaced by drug-sensitive infections, which give us the death attributable to bacterial AMR. And then we also looked at the drug-resistant infections, which were replaced by no infections, which gave us the numbers of deaths associated with bacterial AMR worldwide just in 2019. And these gave us sort of the lower and the upper bounds. So the lower bound was that 1.27 million people died due to AMR, and the upper bound was about 5 million people died in 2019 due to AMR. These also have the uncertainty intervals around them due to the scarcity of the data and the inherence in the modelling as well. And what we modelled was 23 pathogens and interactions with 88 drugs. So or 88 pathogen drug interactions in total. And the whole data included 471 million individual records with over 7,500 study locations within the study. So on this graph, we see the GBD regions down on the x-axis and the deaths, which are in rate per 100,000 population on the y-axis, and the deaths that are attributable to AMR down in the grayed out picture, and those attributable to, associated with resistance in the upper bounds here, with the uncertainty intervals as well. And what we see here is that the highest number of deaths are seen in sub-Saharan Africa. And if we look, Western Sub-Saharan Africa has the highest death, with 27 deaths per 100,000 population, compared to Australasia, where there are about 6.5 deaths per 100,000 population, which is a huge difference. And then when we break this down and we look at the infectious syndromes that cause the highest burden of death, what we find is 3 infectious syndromes cause about 80% of the deaths. And these infectious syndromes are lower respiratory infections, bloodstream infections, and intra-abdominal infections. Then when we break this down a bit further to understand the organisms causing those infectious syndromes, we find that 6 pathogens cause 74% of the infections. And within those 6 pathogens, the combinations of pathogen and drug, there are 7 combinations which cause more than 50,000 deaths within 2019. And the top 3 in the pathogen and drug combinations are MRSA, which caused more than 100,000 deaths in 2019, followed by Mycobacterium tuberculosis and resistance to the first line of drugs, and then E. coli, which is resistant to 3rd generation cephalosporins. And the outcomes of our study were that AMR really is a leading cause of death, and it's higher than HIV, AIDS, or malaria globally, that it causes 1 in 5 deaths in children under 5 years of age, and that the majority of the deaths were attributable to just 7 bacteria. So these bacteria have the highest burden of deaths, but out of these 7, only 2 of them have vaccines or have intervention programs. So that really does start to give us an indication of where gaps are. We see the highest burden is in sub-Saharan Africa, and we think that simple improvements in WASH and infection prevention and control could actually decrease the burden and the deaths of AMR quite easily. And really importantly here, we know where the gaps are, we know what the data looks like, and so this work should really be a catalyst for action going forwards. What we've lacked in the last few years is really implementation to decrease the burden of AMR. I really think that's where we should be going. So thinking a little bit more about this, we know the burden of disease, but what happens about antibiotics? Do we know how many antibiotics are used? Do we know where they're used? Do we know why they're used? And we can speculate about why antibiotics are used. And maybe it could be that the results that we now have from the Gram study is going to make people even more scared of AMR, because we know that many people are being killed because of AMR or are dying because of AMR. So it might be the fear of AMR, it might be a lack of diagnostic tools, or where microbiology is actually performed, it's a lack of trust in the results. It might be that there are high carriage rates of resistance in the population, and then this causes more disease with resistant organisms. And it might be that actually a treating physician or healthcare worker is unaware of the context of a patient sitting in front of them, whether they've previously taken antibiotics, whether they have a community or a hospital-acquired infection. So much of that is really useful to know when treating a patient. So this brings me on to the ADILA project, which is a project where I'm a co-investigator with Mike Sharland based in St George's. And this is a project where we're using antimicrobial resistance data to inform local action, or ADILA, where we're estimating the clinical burden of disease and the appropriate country level prescribing. And this really is based upon the antimicrobial resistance data, together with the WHO essential medicines list, which suggests that certain antibiotics should be used for infectious syndromes. This also brings in the AWARE categories, the access, the watch, and the reserve group of antibiotics, where we have had, or we have guidelines saying that up to 60% of antibiotics used should be from the access group and less from watch or reserve because of the increasing resistance in these groups. But what we have seen is that there are increases of the use of watch antibiotics in lower and middle income countries over the years. So we want to change that. And we actually want the physicians in country to base their empirical prescribing upon the information that they know about antibiotic resistance, the antibiotics available in their country, and to be able to treat people effectively. So our goal is to optimize the use of the surveillance data which has been collected, so reuse data, to develop tools to implement that can be implemented nationally to inform and support countries' policies on improving the quality of antibiotic use. And we split this down into hospital data, primary healthcare, then into the clinical impact and implementation in our study. So the hospital data is really looking to inform the development of facility level empiric prescribing guidelines and targets of appropriate antibiotic use. And this is work where Ben Cooper and colleagues will be modelling the impact of concordance and discordance on patient outcomes. And we'll be looking at the variation between countries and within countries, at the empirical guidelines for the clinical infections based upon the AWARE EML guidelines. And then the AMR and the local prescribing data will be used to integrate into these tools. For the primary healthcare data, we're really looking at the antibiotic prescribing and estimating the distribution of the clinical infections to actually inform the targets for appropriate levels of antibiotic consumption. When we will be looking at the observed versus the expected prescribing patterns and looking at the relative proportions to the AWARE EML guidelines. And we'll also be performing surveys where we're asking experts to really understand the ideal prescribing proportions. In addition to this, we'll be looking at the cost of the prescribing and antibiotics. Then we'll also look at the clinical impact of alternative prescribing, where we can have reductions at a population level. And the really important thing here is that all of these tools will be made available to everyone freely on our website and on GitHub and many, many places. But also that we're going to work very closely with our collaborators, and this work will be implemented in a small number of countries, particularly lower and middle income countries, to actually integrate the tools and pilot the tools that we have. We really want to build capacity. We want countries to be able to do this themselves. So in conclusion, I think the important thing we have now, we have some evidence, and we need to translate that into action. We need continuous quality improvement. We need to advocate for awareness for the delivery of health services. We need improved diagnostic capacity and capacity for data management, analysis, interpretation, sharing, and bringing all of that into policy as well to change what's happening at the country level. I also think we need to learn from COVID-19, where prevention really is key. Rather than trying to put a sticky plaster with antibiotics, we really need to prevent infections before they happen. And I just want to say a big thank you to our group who are involved in this, where we have groups in Oxford, in St. George's, but also those of us who are joining us globally. So thank you very much. And I will pass this out if anybody has any questions.
Well, thank you, Catrin, for excellent talk on the GRAM project and also the new exciting project of Adela. I'm glad to see that you are finally joining us, but also in the background we have Mike Charland. Also welcome to you, Mike Charland. So people can ask questions through the Q&A, and then we will get it as chairs in the chat. But Catrin, maybe a question from me to you. Is there, so there's always a data gap, particularly probably from the low-income countries. Can you say something about what you endeavored doing the GRAM project, having data from low-income countries, and then you have also the lower middle income and the upper middle income? Any differences there, and where should we focus on in trying to improve that?
Yeah, thanks, Heiman. It's nice to start with an easy question. So data gaps, I think we have to acknowledge that there are many, many data gaps, particularly in low and middle income countries, as you were inferring. I would say that I have a lot of knowledge about where data is and where the best data and good quality data is, and that's where I'm targeting, so to speak, or working with collaborators to share that data in those countries. I'm sure there are many data sets that I'm not aware of, and would implore people, if they want to join the collaboration, that they should just get in touch with us and discuss with us whether they can join and be collaborators. I think one thing that we have to say is that although we've collected data and analyzed retrospective data, the best thing right now would be to collect really good prospective data. And in the Adela project, we're really looking a step further than GRAM. We're looking for the clinical data, the microbiology, the outcome, but also the antibiotic use data. And if it's possible to have that on a patient level sort of spreadsheet, that would be fantastic to really understand concordance and discordance in antibiotic usage. That said, that's going to be really, really difficult to start collecting, and we really need to push our ministries of health and our colleagues to start to collect that data and bring it together. One thing that we're planning to do is to use high income data, which is the best that's currently available, to really understand which variables are necessary for our modeling. So if it's possible to remove some of those variables and remodel the data to see how comparable it is with and without those variables, that's what we're going to start with, and then see the data that we have from low income countries, compare how good it is and how good it is for the modeling. So I think, you know, we will start with what we have, but also implore people to look for really good prospective data, Heiman.
Wonderful, thank you, Catrin. So potentially later more room for questions, but I think for the sake of time, we have to move to the next speaker. You already referred to Oxford, Catrin, so now we go to an Oxford speaker from Vietnam, Mrs. Do Thi Nga, and she will talk about C-reactive protein used to optimize community use of antibiotics. And I know Nga very well. She was one time ago a PhD student of mine, and it's great to have you here and to talk about your exciting work on having sort of rapid test results that can have an immediate impact on antibiotic prescribing. So Nga, looking forward to your talk.
Yeah, thank you very much, Heiman. Hello, everyone. My name is Nga Do. I'm postdoc researcher from Oxford University Clinical Research Unit in Vietnam. And it's my great pleasure to join this important webinar to share our work investigating the potential use of the C-reactive protein testing intervention to optimize the antibiotic use in community in low and middle income countries. So I would like to we conducted a household survey in a northern province in Vietnam. Among 1,500 participants, 7% of adults and 16% of children under 5 years old had
So, Nga, I think your microphone is not working very well. At least I hear you not very well.
Can you hear me?
Yeah, now it's good.
Okay. So we conducted the household survey in Vietnam with the 1,500 participants. Among them, 7% of adults and 16% of children under 5 had the respiratory infection in the last 2 weeks before the survey. And of them, nearly 90% used antibiotics, mainly obtained from private pharmacy, following by the primary healthcare center. Only 3% obtained antibiotics from hospital setting. Not surprisingly, the population were colonized very highly with the resistant bacteria to the first line of antibiotics. In another country conducted in 6 low and middle income countries, including Vietnam, Vietnam and Bangladesh show very high density of antibiotic dispensing in the rural area. As you can see in the map, in the one rural area of Vietnam, for every about 500 inhabitants, there was one antibiotic dispensing point. So with this kind of the high density of suppliers, the self-medication were found very widespread in Vietnam and Bangladesh and Ghana, but not much less in Thailand and South Africa, where the regulation is more enforced. The self-medication were considered less time-consuming, cheaper, and in overall more convenient than accessing them through the health facilities. As you can see in this figure, the yellow bar showing for the drugstore and for the mild illnesses, the drugstore were the most common point of contact across in most countries except South Africa and Mozambique, and the factor associated with the treatment stocking normally involves the relevant policy just in the supplier disease severity or whether the antibiotics were intended for a child. We might think that antibiotic use in the community might less concern compared to the hospital use. However, the data from our Bacchus study show that nearly 30% of antibiotic consumption in the community belong to the WHO watch group, as Catrin already mentioned, that raising the resistant risks, and the purchasing watch group associated with the purchasing antibiotics for children and when they purchase antibiotic without prescription. So what we are going to do about this within OCRU with the community-based intervention to improve antibiotic use in the community, we target both supply and demand side. For the supply side, we target the antibiotic prescribing of the primary healthcare workers and the pharmacy. And from the demand side, we have interventions for the community, farmers, and school students. In the primary healthcare, the data from Vietnam show the high volume of antibiotic prescription for the acute respiratory infections. The distinguish between the bacterial infection and the cell-limiting infection is challenged. In Europe, the C-reactive protein point of care test widely used for the primary health care. You may know that the C-reactive protein is an inflammatory biomarker that can help to distinguish between the bacterial and cell-limiting infection that would not require antibiotic use. And with the simple and rapid tests available, CRP test can provide the promising tool to aid the diagnosis and to guide the antibiotic treatment. In high-income countries, there's a number of the interventions show the impact of CRP point-of-care testing in reducing over antibiotic prescription safely but in low and middle income countries, very few studies conducted. Our first trial conducted in Vietnam and published on the Lancet Global Health within my PhD supervised by Heiman, and following by another trial conducted in Thailand and Myanmar, confirmed the efficacy of the CRP intervention in reducing antibiotic prescribing without compromising patient recovery. However, all these studies conducted in the research context with very close support and monitoring from the study team that might influence the prescribing practice. So to better inform the wider scale implementation of the CRP interventions, the pragmatic trial will be needed. And I'd like to move to our ICAT trial. The trial conducted in 48 common health centers in Vietnam through the pragmatic cluster randomized control trial, with 24 centers use the CRP test and 24 centers follow the routine care. The target population was the patient aged from 1 to 65 years old, presenting with acute respiratory infections less than 7 days. All the AI cases were extracted from the electronic database of 48 common health centers. The database was used for the health insurance reimbursement purpose. Subsample of 1,400 patients in each arm were followed up by a phone call to collect the data about the safety endpoint like duration of symptoms and subsequent antibiotic use. We also link to the hospital data at the district level and provincial level to add the safety endpoint of the hospitalization rate. In the interventions, we use the CRP test in the absence of the danger sign of the severity. If the CRP value fall below 10 milligram per liter, no antibiotics are recommended. It means wait and see. If the CRP value fall between 10 to 40 milligrams per liter, antibiotics are unlikely to be needed, but then healthcare worker can combine with the clinical findings to decide. And for the patient with the CRP value above 40 milligrams per liter, then antibiotics are recommended according to the local guideline. I will not go into the detail in the trial profile, but then we have nearly 40,000 patients included in the intention to treat analysis, and among 18,000 patients registered in the electronic database, 2,600 patients received the CRP test and were analyzed in the per protocol analysis. This table shows the baseline characteristic of the patient by arm. As you can see, the female accounted for more than 50%. The children accounted for nearly 30% in both arms. For the ARI symptoms, the soft spot.
Your microphone is fading out again, Nga.
Oh, sorry.
Yeah,
can you hear it better?
Yeah, good.
Okay. So among the AI symptoms, sore throat, cough were the most common symptoms, followed by a fever. And you can see the higher fever rate in the intervention group, but we see the same trend in the preceding year. The upper respiratory infections accounted for nearly 90% in both arms, and the baseline prescription rate really high, nearly 100% of the AI patients receive antibiotic treatment. For the primary endpoint, so looking at the intention to treat analysis, we only see 5% reduction in antibiotic prescription in the CRP intervention group compared to the routine care, but larger reduction were obtained in the per protocol analysis with 70% only compared to nearly 100%. The similar trend we see in the A groups. When the half of the CRP tested patient received the CRP result below 10, and among them only 50% receive antibiotic prescription. So when the healthcare worker use the CRP test, they discomply with the recommendation. This table summarizes the secondary endpoints, and you can see there's not significant difference between control and intervention arm relating to the subsequent antibiotic use or time to resolution or reconsultation rate. The intervention were associated with a small increase in the using of watch group antibiotics and the increase in the referral rate. This figure just visualize the similar trend in the duration of symptom between arms, indicating that the intervention did not compromise patient recovery. However, also we achieved the positive outcome. We learned the several challenges during the implementation, and one of the main things is that among the patients recorded in the Common Health Center electronic database, there's number of the patients did not attend the center in person, but they were treated remotely, and only 40% attending the CSC in person. So the patient did not visit the CSC in the person. The healthcare worker could not offer them the CRP test. So only 16% of the patient with the ARI exposed to the intervention. That is several limitation in our study. So according to the data from the electronic system, the uptake rate is really low with only 40%. So we introduced the study logbook to try to exclude the patient that did not visit the CSC in person. Then we have uptake rates up to about 40%. Comparing to the pragmatic trial conducted in England, they also have a very low uptake rate of less than 1%, and they couldn't find any significant reduction in antibiotic prescription. There's the other limitation in our trial is that we, by introducing the logbook to have more accurate uptake rates, but then without the sufficient without supervision from study team, then the data is not valid enough for our per protocol analysis. So we have to compare with the whole population from ITT. And also the trial conducted in the early phase of the COVID-19, even where the no positive case found in the study area, but the patients still afraid and hesitate to come to the healthcare centers, then the number of visits and prescribing patterns might be influenced. So with that limitations, there's question will be what the population impact with the low uptake rates, then whether the intervention is clinical important and the cost effective, because with the best case scenario, if we have 30% reduction in the PPA analysis and we have 40 uptake rates according to the study logbook, then we have only 11% reduction in the whole population impact. So we understand that even the point of care testing work in the outpatient setting, many people might go to the private pharmacy or they get antibiotics from elsewhere when they were not prescribed antibiotics. You can see some data from Vietnam with 60,000 private pharmacy. They are the main source of antibiotics for the mild illnesses. And antibiotic dispensing regulation was not enforced. Antibiotics is major source of revenues of the private pharmacy. That's difficult to change their practice. So we conducted a study to explore the feasibility, acceptability, and willingness to pay for the CRP point of care test. So I would like to share some data from that study. We have 520 customers participated in the survey, and nearly 80% of them believe that the CRP test is suitable to implement in the community pharmacy. However, 30% only feel comfortable if the nurses are staffed with the necessary nursing skill to perform the test. And nearly 50% accept the CRP test to be done by the community pharmacist. The participants also show the willingness to pay for the CRP test around $2.3 US, a bit lower than the medicine cost of around $4 US. So for the future works, our findings from this trial confirm the effectiveness of the CRP intervention in the real-life condition of routine practice. However, with the challenge and the barrier we learned during the intervention, we performing the process evaluation to understand the perspective from multi-stakeholder, to understand how to integrate the CRP intervention in a more comprehensive AMS program to obtain the optimal impact in reducing antibiotics use in the community. This study was funded by the Australian government and UK government through FIDE, the Global Alliance for Diagnosis. And I would like to thank the study team, the local partners, and also the 48 Common Health Center doctors, nurses, and the patients for their great collaboration during the implementation of the trials. And thank you very much for your listening.
Thank you very much for keeping this right in time and for this great work. We received a few questions from the chat, so I will forward it to you. The first one was from Kumud Kafle. What was the source of the prescription in your study? Was it a paper prescription or electronic?
Yes, so they have both paper to the giving the patient by the paper prescription, but then they also documented in the electronic system for the health insurance reimbursement.
Okay. And I have another question that is a broad question, but I still think it's interesting, from Godwin Pius Ohemu. He asked, is cutting down the use of antibiotics the only option for controlling the upsurge of AMR? What other action steps could we do to control the increasing cases of AMR in different settings?
Yes, so I think like in during the COVID pandemic, we see the reduction in the ARI consultation in the primary care. I think one of the main related factor is wearing mask, and when the school closed, then the transmission have less opportunities. So I think for reducing antibiotics use in the community, besides increasing the capacity for diagnostic, we also can have other alternative solution like increase the hygiene.
Yeah, I totally agree. And immunization is another probably option to reduce the...
Yes, I agree. Yeah.
Antibiotics. And one last question that is from my side. I don't really know the figure in Vietnam. Who are the main prescribers of antibiotic? Is it more the nurses, the doctors, and among doctors is more the general practitioner?
The main prescribers in Vietnam are the doctors in the hospital. But then for the grassroots, like primary healthcare, sometimes they allow the assistant doctor who is not received the university degree, but they might have a shorter training, and then they allow to prescribe, but not pharmacists or nurses, never prescribe antibiotics.
Okay, good. So thank you very much. We are right in time and do very good work. So congratulations for all this research on the use of CRP, especially. I'm impressed.
Thank you very much, Pierre.
Thank you. So we will move to the next speaker. She will talk about the International Center for Antimicrobial Resistance Solutions, the ICARS, Partnering for Impact. Nandini Sreenivasan is a medical doctor and epidemiologist with diverse experiences working on infectious diseases in global health settings. In her current role as an implementation research advisor at the ICARS, she collaborates with partners in low and middle income countries to co-develop projects contextually specific, technically sound, and operationally feasible. So Nandini, the floor is yours.
Thank you so much, Pierre, and thank you for inviting ICARS to present today. So as Pierre mentioned, ICARS stands for the International Center for Antimicrobial Resistance Solutions, and I'm a research advisor there. And today I'll be talking a little bit about what ICARS is, what we do, what our approach is, and then finally at the end I'll provide a brief overview of some of our ongoing projects. Sorry, I'm just trying to get my slides to move. Okay, did they move on your end? Okay, great. So ICARS is an international organization that partners with governments in, in low and middle income countries to co-develop and test context-specific solutions for antimicrobial resistance using a One Health lens. ICARS was initiated by the Danish government in 2018 after dialogue with the World Bank. We actually became a self-governing independent organization last year, and we aim to attract funding from member states as well as from foundations. We are global in our scope of work as well as in our staffing, and we currently have 24 employees from 13 different countries. So a little bit about what we try to do at ICARS. So I think, as many of you know from your own work, there are many AMR intervention projects that have been conducted over the years. However, even among the ones that have been successful, very few have actually continued after the projects have ended, and even fewer have resulted in large-scale implementation. There are a number of different reasons for this, as I'm sure many of you know. Some of this could be due to a lack of political commitment or a lack of policies which would mandate or require some of these changes. It could be due to a lack of local ownership, engagement, or behavioral changes, or it could be due to a lack of capacity, whether that be human, infrastructural, or operational resources. So it's essential that interventions, for them to be scalable and sustainable, it's essential that they're based on research that has both an intervention and an implementation component. So at ICARS, we aim to co-develop these sustainable solutions by providing funding, expertise, and support to intervention and implementation research projects. So these sustainable solutions need to be guided by problems that countries have actually identified and prioritized, rather than adopting a one-size-fits-all approach. And then along these lines, we want solutions to be context-specific so that they're tailored to local needs and local challenges and take into account local evidence. We aim for these solutions to be owned throughout the whole chain, so that with buy-in from all stakeholders, from the government level to practitioners and researchers. We aim for them to be cost-effective, especially in settings that could be resource scarce. Some of our other aims within these solutions are that we want to make sure there's relevant capacity locally to support the implementation of these solutions, and that we pay close attention to some of the enablers and barriers of behavior change, because without actual behavior change, it would be hard to make any solution sustainable and have a true impact. Last but not least, we also want solutions to have political commitment. So at the end of all this, the evidence that gets generated can actually be translated into policy and action. So this is an overview of our strategy at ICARS. We work under 4 pillars that are interconnected. Within the first pillar, which is testing solutions, we work in partnership with low and middle income countries to test solutions using implementation research to actually generate new evidence in a local context. This is most of our projects actually fall under this pillar. So a lot of our demonstration projects, which I'll talk about later, fall under this. So under pillar 2, under pillar 1, we're generating new evidence, but then under pillar 2, we look at existing evidence from countries and try to identify ways in which that evidence can best be translated into policies, programs, and practices. Pillar 3 is our advocacy and communication pillar. And under that pillar, we have a particular focus on trying to communicate the importance of intervention and implementation research as a tool for tackling AMR. And then finally, our 4th pillar, which is capacity building, that really focuses on targeted capacity building, and it aims to help deliver on some of the interventions and solutions that are identified under pillar 1, 2, so under the solutions that we've identified. So for example, under pillar 1, maybe there's a need to have a lab component, and then under pillar 4, we could be doing some lab capacity strengthening to help deliver on that project. So this shows an overview of how we do this. We use a top-down, bottom-up approach. So from the top down, we work with the ministerial level to engage with the government and to secure political commitment, which would eventually scale up project findings at the end of it. And we also aim to make sure that it aligns with their national action plans. By using a bottom-up approach, we ensure that the projects are developed by local researchers, and use local evidence and knowledge, and we aim to build on existing evidence already. In addition, we also recognize that we cannot deliver on these projects on our own, so we're keen to establish partnerships with other organizations and institutions. This also helps avoid duplication and ensures that we build on existing initiatives. This table provides a brief overview of some of the partners that we're currently collaborating with. As you can see, it covers a range of international organizations and foundations, a number of national and international networks, existing AMR initiatives, research institutions, as well as the private sector. So there's a whole range of partners that we have. So moving on to some of our ongoing projects. This project is one that we're working on in Vietnam. This is an animal health project, and it's being conducted in partnership with the Ministry of Agriculture and Rural Development. This project aims to tackle the overuse of antibiotics in pig production, and more specifically, the use of colistin, which is used both therapeutically and prophylactically. Under this project, we're working with the ministry, with local farms, with vets, and with research institutions in the country to implement alternatives to colistin. So this could be vaccination, or it could be other less critical antibiotics. From this project, we hope to show that a reduction in colistin use is both feasible and also economically viable for farmers. And we also hope to provide evidence that would inform legislative changes to limit, if not ban, colistin use. One of our other projects is a human health project in Georgia, where we're partnering with the Ministry of Health. And this project aims to tackle the overuse of antibiotics for surgical antibiotic prophylaxis due to a lack of country-specific guidelines and regulations. Under this project, we're working with national health authorities, with local research institutions, and with hospitals to test new guidelines for SAP in 10 different hospitals. These guidelines have been developed based on the WHO Stewardship Toolkit, and the project itself is actually also a collaboration with WHO Europe. The project aims to secure the development of guidelines, but also to ensure compliance to the guidelines, and at the same time aims to identify barriers and facilitators for stewardship. So this is an overview of all of our different projects. So there are 3 different categories, and the ones in purple are our demonstration projects, and those are the Pillar 1 projects that I mentioned earlier. We also have projects that are being conducted in partnership with other initiatives such as JPI AMR, and those are the ones that are shown in green. And then finally, we have a few co-funded activities that are in blue. So as you can see, our focus is global. We currently have more than 10 projects, and they're at varying stages of co-development across Latin America, Asia, and Africa. These projects span the One Health spectrum, so some of them are animal health focused, some are human health, some are environmental, but there really is a range. So a little bit about our governance. We have a board of directors, which is international, which consists of a number of different international members. That's our governing body, and then within ICARS, we have our executive management, as well as our staff. Another part of our governance structure is our technical advisory forum, which is external, and they provide scientific guidance, and they also review our project proposals, and that helps us ensure that there's a high level of scientific integrity and quality in our projects. We also have underway, or in development, we have a strategic advisory forum, which will be led by the incoming executive director. Oops. So this is just a brief overview of our board members, and similarly, our technical advisory forum. And that was it for a very quick overview of ICARS.
Wonderful. Thank you for presenting this, Nandini. And very impressive to see all the work that you're doing across the globe. And so we're talking about low and middle income countries. So there are so many initiatives now. You have the Fleming Fund, Wellcome Trust, GARD-P, JPI, AMR, and everybody's sort of doing all the things in low and middle income countries. How do we make sure that everything is aligned and that we're sort of in each other's way, that we're really making progress rather than sort of funds flowing in these countries and with sort of contradicting projects?
I mean, I think that's actually a real challenge. We try at ICARS to make sure when a country comes to us and is interested in working with us, we try to make sure that as part of their application, they collect any existing information, and we ask them specifically about existing initiatives and what other activities are ongoing, because we don't want to duplicate efforts. So for example, we don't usually work on establishing extensive surveillance systems and things like that, but it is a challenge, I agree.
Yeah, because sometimes it's sort of pushed by the funding organizations what a country does, and that's really nice to see that you really have a sort of top-down and a bottom-up approach, and then really trying to align with the local context. But I was wondering, can we sort of come that every country have their own priorities, and of course with certain advisors, and that sort of the different organizations and research institutions can sort of buy in different projects that the country sort of market, or that they, rather than so that you have a sort of a roadmap for each country, and different organizations can sort of buy in, okay, I want to sort of adopt this part of your roadmap, and then things potentially have a real impact for the long term, rather than having different people come in with different projects and not always very complementary. Any?
So right now, we're mostly, at least with the projects that we have right now, they're mostly ministry-led. So the ministry comes to us, and then we work with the ministry to figure out what are the country's priorities, what is it that they want to focus on, and then a research institution might carry out a component of it, but it's not. I think from what it sounds like, you're saying different institutions could just come to us from one country and say they would like to do this or this or this.
Yeah, I was wondering that if you, so rather than having one small component of your whole AMR problem is being solved, rather you have this whole package as a country, and that you make sure that, okay, because if one thing is done, that very soon afterwards, you want the next thing to be done, and to make sure that everything is funded along the way, that you sort of have different organizations taking on various projects, and that it sort of smoothly progresses and not sort of comes to a halt, which often happens as well.
It does, and I mean, in an ideal world, we'd be able to do all that. Our projects are targeted, and the ministries do have to prioritize what they want their projects to focus on. We work with them on that, but we can't tackle everything, obviously.
That is right. And then I think there's a question coming in. I'm not sure if this is for you, but let's see. So what types of barriers did you, how do you make sure other country stakeholders beyond the ministerial level and universities are being engaged in the country-specific projects? From Eric Vennant.
How do we make sure that what?
How do you make sure that other country stakeholders beyond the ministerial level and universities are being engaged in the country-specific projects?
So usually quite early on, we try to have them map out some of the different stakeholders. It doesn't have to be a university, it could also be a research institution. If, for example, I'm working on a project in Georgia, which involves poultry farmers. So in order to work best with the poultry farmers, we've identified some farmers some farms that we'd like to work with, and we've been having a series of meetings with these farms. So that happens quite early on. Once we figured out what the project focuses on, that we try to engage with all the different stakeholders and also the local stakeholders. Also to make sure that at the implementation level, the farms or the vets or whoever would be collaborating with it, they've also bought into the actual project itself, because I don't think we could just show up on a farm and then just decide to do something. We also want to make sure that the intervention would work for them, or if, for example, we're changing antibiotic types, that's something that would work for the farmers and that they're interested in actually doing that. So we try to engage with different stakeholders across the board.
Okay, thank you. A bit more specific question concerning guidelines from Goodwin. So what type of barriers do you face when you want to contextualize or localize a WHO recommended guideline, and how do you overcome these? So if you want to sort of implement a guideline and you want to contextualize, any examples of that? Have you been involved with that?
Well, one of our projects, the Human Health Project in Georgia, is focused on developing guidelines actually as part of the project. And they're currently in the middle of doing that. That's not one of the projects I'm working on, so I'm not sure what the main challenges they face so far are, but I imagine if you're taking guidelines and putting them into a local context, some of the challenge would also be figuring out which antibiotics are actually readily available, whether there's access at different hospitals. Are these guidelines actually implementable at hospitals across, not just tertiary care hospitals, but also some of the lower level hospitals, because I imagine access would vary depending on where the hospital is located, for example. But that being said, I haven't worked on that project, so I'm not sure which specific challenges they faced, but I can find out.
Yeah, but I think you touched on an important point is indeed, if you want to have a certain antibiotic, make sure in the first place it's there. But it could be also very important that sometimes they don't know they need a certain antibiotic. So to making the case because of a certain epidemiology of a certain infectious disease and they don't have an antibiotic to treat it, like we've seen with melioidosis in Cambodia, that they didn't have the right antibiotics. But after doing good microbiology, they found it, and then now they do have the right antibiotics, the mortality went down. So it is important to still make that case. And one maybe last question is...
Can I ask one, Heiman?
Yeah, go ahead, Pierre.
Okay, thank you. Congratulations, Nandini. I was really interested, and I had one question. I was impressed by the project in Georgia about the surgical antibacterial prophylaxis. And do you sometimes, if you identify a very successful project, try to disseminate it to your other partners, country partners, even if they did not ask themselves for that, but if you think it's a very good idea, can you disseminate?
We would very much like to. We are still quite new at ICARS, and so most of our projects are also new, so we don't have any projects that are actually finished yet. So for example, the Georgia Human Health Project, I think it was approved around a year ago, and I think it's been in the implementation phase for the last 6 months, I believe, maybe a little bit longer, and it has a duration of 3 years. But absolutely, we would very much like that countries share their success stories. Something that we've talked about is, as the projects develop, if we could have webinars where countries can share their lessons learned, where they can share their success stories and their challenges. So we definitely would want to share that between countries, especially if things go well. I mean, even if there are things that don't go well, to focus on what we can improve on or change.
Well, thank you, Pierre, and thank you, Nandini. So success stories, that's exactly what we want. And we hope to hear some successes actually in the next round of speakers. We're going to present the work they've done with the grants they got from the ISAC. And the grants are really focused on antibiotic use and misuse and resistance in low and middle income countries. So we look forward to hear the results from these projects or how they're progressing. And the first speaker in this round is Dr. Bianca Graves. She's an infectious disease physician and a microbiologist in Brisbane, Australia. And she's passionate about enhancing the microbiology laboratory capacity in the Pacific to improve AMR surveillance and ultimately patient outcomes. So that is a great thing to do. And we look forward, Bianca, to hear more about AMR in the Solomon Islands. So I think you will present on that. So we look forward to your talk.
Okay, good afternoon, everyone. So for those who don't know, the Solomon Islands are a group of islands to the east of Australia with a population of 700,000. And the laboratory that I work for in Australia has had a long-standing affiliation with the National Referral Hospital in Honiara, which is the capital. And despite the fact that there is very little data around the burden of antimicrobial resistance that in the Western Pacific region, we noted that the Solomon Islands appeared to have a very high rate of ESBLs. And not only that, we noted that that rate tended to fluctuate quite significantly from year to year, indicative of the fact that there was obviously some issues with the quality of susceptibility testing coming out of the laboratory. And as we know, it's almost impossible to address AMR without reliable laboratory data. So with this ISAC grant, it's allowed us to support the laboratory in their surveillance efforts and to obtain some of that data to help guide AMR interventions in the country. So together with the laboratory, we came up with this project with multiple components. So the first component was to perform an assessment on the quality of results coming up of the laboratory and to identify how we could help support the lab to improve them. The second component was to look at phenotypic profiles, specifically of ESBL producing organisms, and use that information to help develop antibiotic guidelines to support empirical treatment. Thirdly, we were hoping to sequence a subset of the ESBL isolates to look more at the molecular epidemiology and get an idea of what the transmission pattern was and whether it was a community transmission or if there was an issue with hospital infection prevention. And lastly, we wanted to perform a point prevalence survey looking at the rate of ESBL carriage in the community. And that's mainly because we know that passive surveillance from clinical isolates tends to overestimate AMR. So that would give us a better idea of what the burden was in the Solomon Islands. So in terms of the quality of results coming out of the laboratory, we organised for the NRH lab to send us all of their gram-negative isolates that they identified were resistant to third-generation cephalosporins. So they've been forwarding us those isolates since 2020, and we've done some interim analysis. Obviously don't have the complete data as of yet, but what it demonstrated was that there was quite a high rate of organism misidentification, particularly a failure to recognise organisms that had intrinsic resistance to cephalosporins, and also that 12% of the isolates that were received were actually testing susceptible in our laboratory. So I guess this is reflective of some of the challenges of performing bacteriology in these resource-limited settings, but it did provide a useful starting point for us in terms of how we approached reviewing the workflows in the laboratory and where we needed to focus our efforts for staff training. So we then had great access to antibiotic testing in our laboratory, so we were able to put together a phenotypic profile of the ESBL isolates that were coming from the Solomon Islands. And what we realised was there was actually a very high rate of a multidrug-resistant phenotype. So over 50% of the ESBL isolates were resistant to a combination of Bactrim, gentamicin, and ciprofloxacin. And I guess that's important information because there are limited options for antibiotics in the Solomon Islands, and that phenotype is likely to drive carbapenem resistance without an appropriate stewardship interventions. We then performed that slide there. We then performed sequencing on a subset of the isolates, and what we found was there was actually a diverse range of MLSTs and no evidence of clonal spread of a single ESBL isolate, which was indicative, I guess, of the fact that there was not actually a problem with transmission within a hospital setting, but rather that patients were coming into the hospital with these ESBLs that they had acquired from the community. In terms of the last aim of the project to perform a point prevalence survey, we haven't actually been able to achieve this because some islands closed their border for a long time due to COVID, so we haven't been able to get across there to do that, but we're hoping to do that later this year, and that will give us a better idea of exactly what the burden is in the community. So what are we doing with this information? We have established weekly virtual laboratory rounds with the NRH laboratory. So we discuss difficult isolates and the results of their susceptibility testing and ensure that they've got appropriate reagents for testing and support them in that respect. We always feed back to them results of our informal proficiency testing, and if there's any issues with the workflows, then we can troubleshoot that with them. And in collaboration with another organisation, the Pacific Region Infectious Disease Association, we've actually developed a scientist training course. So one of the issues in the Pacific is that there's no specific microbiology training for scientists, and there's only one microbiologist in the whole region in Papua New Guinea. So we developed this training course, which has been rolled out in not only the Solomon Islands, but Timor-Leste, Samoa and PNG, and that's aimed at improving the training of scientists in microbiology. And we're also assisting the lab with this data to develop antibiograms that can support antimicrobial stewardship in the hospital. And that's obviously done with a huge team of people, both at the NRH laboratory and Pathology Queensland. Thank you.
Thank you very much, Bianca, and congratulations for this work, especially during COVID time.
It's been great though, because we realized that we can actually give that support from afar with virtual laboratory rounds, which we wouldn't have done without COVID.
Okay, so we have no question on the chat, only a congratulation from Sabine Korf, who say thank you for all the knowledge shared. And maybe for the sake of time, because we only have just 5 minutes for each speaker, we will move to the next speaker.
Sure.
We were supposed to be Eric Coffey, but he's at the WHO meeting, so he will be replaced by Joseph Acolatse. He's from the same team at the Cape Coast Teaching Hospital in Ghana, West Africa, and he will talk about the prevalence and the drivers of over-the-counter antibiotic sales among community drug to develop mitigatory behavior change intervention. So Joseph, the floor is yours.
Hello, thank you. I'm just trying to get my slides up. Hello, my name is Joseph Acolatse, and today I'll be presenting on behalf of Dr. Eric Kofi Njedu. Our topic is the prevalence and drivers of over-the-counter antibiotic sales amongst community drug outlets to develop mitigatory behavior change interventions. Our research overview, antimicrobial resistance, we know is a recognized health problem. And with the Graham report, which we had the pleasure of seeing earlier, showed Western Sub-Saharan Africa being one of the highest regions with mortality for AMR specific and AMR associated illnesses and deaths. And there's literature and reports from Ghana and other LMICs where we've seen antibiotic dispensing in community outlets without prescriptions, where this practice is irrational. And also we had the opportunity to see the Abacus reports, the Abacus study results, where this was also confirmed that within Ghana, antibiotics are purchased from the community, sometimes without prescriptions. So the aim of our study was to first determine the prevalence of illegal antibiotic dispensing. Secondly, to assess the knowledge, attitudes, and practices by dispensers on AMR. And finally, last but not least, we wanted to identify key determinants of over-the-counter antibiotic dispensing. And all these, especially from point 3, where we'd use in-depth interviews, will be used to map the determinants to a behavior change framework, where we chose the behavior change wheel using the COMBI framework. That's for capability, opportunity, and motivation. So once they are mapped there, we will design interventions based on the outcome of the behavior change wheel, so that we could actually tackle this problem and not just leave it at generating data on the situation. So our research design, we had about 4 phases. In the first phase, we utilized the simulated client methodology, where we trained simulated clients on two disease scenarios. The first was upper respiratory tract infections, where we designed a protocol for the simulated client to enact having an upper respiratory tract infection. The second scenario was pediatric diarrhea. So for the first scenario, we actually reversed levels of demand. Each scenario had 3 levels of demand to see how much it took to push the dispensers to actually give antibiotics. For the first scenario, that was for an upper respiratory tract, we chose an antibiotic of interest, namely azithromycin, which is in the watch category of the WHO Access Watch Reserve list. So for the first level, the patient goes and outright demands azithromycin with no explanation. Should it not be dispensed, he goes to a second level where he explains the symptom of a colleague or a brother of his, where he states most of the common symptoms as per the Ghanaian standard treatment guidelines of a viral upper respiratory tract infection, because we wanted to assess a viral upper respiratory tract infection based on the differences in presentations that they will have. So once he presents this, then we would see if the pharmacy will still dispense azithromycin, since we believe that additional knowledge might push them to suspect that instead of it being viral, it may be bacterial. And the third level of demand was where he just asked for any antibiotic if they were still hesitant to dispense. So that was for the first case scenario. For pediatric diarrhea, we reversed the order where the client goes and explains the symptoms of a child at home, which are in line with viral pediatric diarrhea, i.e. a self-limiting case. So once she did that and there was no dispense, she would ask for any drug which could help relieve the symptoms. And finally, she would ask for amoxiclav because she believes that that antibiotic would help the child due to previous encounters. So we managed to include 134 pharmacies and 131 OTCMS, that's over-the-counter medicine sellers. A distinction in Ghana is we have pharmacies which are allowed legally to dispense antibiotics with prescriptions, whereas OTCMS, the over-the-counter medicine sellers, are not allowed to dispense or even stock antibiotics at all. And so for this, we looked at 2 practices, which was bad practice, i.e. both case scenarios ending with a dispense since there was no prescription presented, and good practice where the pharmacist or the attendant at any of these outlets, either for pharmacies, told them that this was not appropriate and gave them any other medications to help relieve the situations or refer them to the hospital. And for OTCs, the outcome for good should be we do not stock antibiotics at all. And after that, we decided to also go on to a questionnaire phase. So the questionnaires focused on the sample from the simulated client phases. We wanted to do this to assess their reported versus actual practice, because we know that sometimes due to desirability bias, questionnaires may not be too effective in terms of assessing actual practices on the ground, because this action where they do dispense is illegal. So the fears of probably some adverse events, especially to them in terms of maybe suspension of license, actually might prevent them from actually being honest about their practices. We've started a questionnaire.
Sorry, Joseph, but it's only short presentations now, so you have only about 1 more minute. Okay,
so after that, we went in-depth interviews, and then we mapped them to the behavior change wheel. So for our results, this is from the SCM phase. We found that there was a significant difference between metropolitan cities. And also we found that for the upper respiratory tract infections, we found a significant difference among the demand levels for pharmacies. So this is just the summary of the good and bad practices, where you see a high amount of bad practices. So for the totals in one metropolitan, we had about 84.1%. And this was seen across all the different metropolis. And we see the demand levels for case scenario 1, level 1 was quite high in pharmacy and low in OTCs. This followed through level 2 as well. But with the case scenario 2, they were fairly equal. And then finally, when there was a dispense, we found out within pharmacies, not all of the people who dispensed in pharmacies were actually pharmacists. And so we have this interesting graph which shows that even when the pharmacist was present, which is the yes, the bad dispensing was still quite high and the good was low, even though this was quite reduced in those who were not pharmacists who ended up dispensing antibiotics. And so we've currently completed a simulated client. We are still following up on the questionnaires because we do have some people not responding immediately, wanting time to think about it before we actually go and administer it. And we've begun recruiting for the in-depth interviews, which we used purposive sampling. And we will develop the interventions after we completely collect all the data, and then we'll begin a manuscript preparation. These are the list of investigators, and thank you for your time.
Thank you, Joseph. Really interesting to see, but also a bit worrying to see the bad practices, even though there's a pharmacist there. So thanks for sharing that with us. But for the sake of time, we go to the next speaker, Puteri Zamri, and she's a senior clinical pharmacist, experienced in managing critically ill patients, especially focusing on infectious disease management. She's currently interested in the research area of infectious diseases and pharmacokinetics and pharmacodynamics of antibiotics. She's now serving the Ministry of Health in Malaysia and is currently affiliated as a PhD student at the University of Queensland in Australia. So, Puteri, we look forward to your story on the optimized dose of polymyxins in gram-negative infections. And I guess it will be in Malaysia. So, look forward to your talk.
All right, thank you, Pierre. Can you see the slides?
Yes, we can.
Okay. Hi, thank you for having me today. My name is Puteri Zamri. So I'm a clinical pharmacist in the Ministry of Health Malaysia and also a PhD student in the University of Queensland, Brisbane, Australia. So my research supported by the Isaac grant in 2020 is actually on the optimized doses of polymyxins to improve outcomes for non-critically ill and also critically ill patients with multidrug-resistant MDR gram-negative bacterial infections. So as we know, sepsis is prevalent in low and also middle income countries, such as Malaysia as well, and which leads to ICU admissions in Malaysia. And the MDR and Acinetobacter baumannii and also Pseudomonas aeruginosa are commonly associated with severe infections. And the use of colistin and polymyxin B has research and also tremendously increased for these few years. To manage these difficult to treat infections. So this study actually aims to describe the pharmacokinetics of colistin and also polymyxin B, and also the variables that affects the PK parameters in critically ill and also in non-critically ill patients in Malaysia. And we also see whether the current dosing regimens achieve the PK/PD exposures associated with efficacy and also to limit the likelihood of toxicity. And lastly, we would like to as well to develop clinically relevant dosing guidelines for both of the polymyxins. So the study is actually a prospective open-label two-center, which involves two centers in Malaysia, which is the University Malaya Medical Center in Kuala Lumpur, and also Hospital Selayang in Selangor. So we are looking into the population pharmacokinetic analysis of colistin and also polymyxin B in these Malaysian patients with confirmed MDR and Acinetobacter baumannii and also Pseudomonas aeruginosa infections. So drug administration of both of the drugs were given according to the IDIC guidelines on the optimal use of polymyxins in 2019. And we have already collected serial blood samples across 7 predetermined time points during a 12-hour dosing intervals onto separate days between day 1 until day 2 and day 3 until day 5. So blood samples were centrifuged immediately at 4 degrees to separate the plasma. It was stored immediately in negative 80 degrees for shipment from Malaysia to the University of Queensland's Centre for Clinical Research for Bioanalysis. And as for now, and the quantification of colistin and polymyxin B has been done using validated UHPLC, and also the pharmacokinetic analysis will be done by using P-metric software. And we have also done preliminary data on using non-compartmental analysis using Phoenix with non-lin. So this data has been presented as a poster presentation in ACMID 2022, just recently in April. Besides that, we also see on the microbiology cultures and also minimum inhibitory concentration determination. So the isolates from both of the centers were actually transferred from Malaysia to UQCCR for the determination using the recommended broth microdilution method, BMD. So the current progress, so the total number of patients recruited since October 2020 until December 2021, we managed to recruit 55 patients and amounting to 401 plasma samples with 551 bacterial samples from both of the sites. And each of the clinical outcomes from each of the patients recruited were discussed among treating physicians involved in the study. And I've also completed MIC determination of all the bacterial isolates earlier this year. And as for the quantification, polymyxin B has already been completed for now, and I will
I have lost connection, or
yeah, Puteri, we don't hear you. I think we lost it. So that was the last slide anyway. So I think we had most of what she wanted to tell us. That was quite interesting too. But Heiman, if you agree, we can do the wrap up. And if Puteri join us, we can ask the question later on.
yes, agree.
Okay, it's because we are almost at the end of the webinar. I first want to really thank all the speakers that have been very interesting, very broad topics from all over the world, and quite enthusiastic projects, because most of them are improving our knowledge and our tools to fight antimicrobial resistance. So I was very glad to listen to all of these talks, and I think on behalf of APUA and on Isaac as well, it's very interesting that we still have this kind of meetings together to exchange data and knowledge. So thank you all, and thank you for people who participated, the more than 200 people that were connected from everywhere. Heiman?
Yes, I fully agree, and it's really great to see indeed also the projects from the different grants from ISAC. And so again, there's a new round, and so please apply, and we hope to see more of these speakers from these projects in the next webinar next year. So thank you all, and enjoy your day.
And hopefully we all meet in Australia, and all those who can join us at the ICC by the end of November. Please join us. It would be a pleasure to really meet people more than just by a webinar.
Have a good day. Thank you all. Bye.
Thank you very much.